Dr. Vaou is the Director of Movement Disorders and DBS at University of Texas Health in San Antonio. Prior to that, she served as the Director of the Movement Disorders and Deep Brain Stimulation Center at St. Elizabeth's Medical Center in Boston. Her expertise is treating patients with Parkinson's disease, atypical Parkinson's, essential tremor, and other movement disorders. She is also a board-certified sleep specialist and treats sleep disorders in patients with movement disorders. Her passion is in DBS, sleep disorders, and Parkinson's disease, and she's also skilled in Botox injections. In her current role, Dr. Vaou is the Vice Chair of Faculty Development at University of Texas Health in San Antonio. After receiving her medical degree from Semmelweis University of Medicine in Budapest, Hungary, Dr. Vaou completed her neurology residency at New York Medical College and served as a chief resident. She then pursued fellowships at Boston University School of Medicine in movement disorders and in sleep medicine. Following her fellowship training, she moved to Minneapolis at Norin Neurological Clinic, where she developed a robust movement disorders clinic. Following her passion of teaching and research, she returned to Boston Medical Center at Boston University School of Medicine to become a member of the Movement and Sleep Disorders team and served as the Assistant DBS Program Director. Dr. Vaou is actively involved in medical student education. She actually had a program earlier today she was telling us about. She has served in the role of Neurology Clerkship Director and the Neuroscience Course Director at BUSM. Under her guidance, the neurology clerkship and the neuroscience course were rated among the top evaluated courses. She has also served as the neurology clerkship director overseeing the Tufts and BUSM medical student education, as well as the BUSM PA student program. Dr. Vaou has received national and regional awards for education. She was also selected to participate in the nationally esteemed program by the Academy of Neurology, Women Leading in Neurology. Dr. Vaou also participates in clinical research, evaluating novel pharmacological agents and patient education in Parkinson's disease. She's very involved in raising awareness of early Parkinson's disease and DBS treatment and PD in women. She's also very passionate about genetic testing in people with Parkinson's disease, with a particular focus on the Hispanic population. Thanks so much for joining us today.
Well, thank you so much. Wow, what a wonderful welcoming and introduction. I love your enthusiasm, and it kind of matches my own. Speaking for sleep, speaking for anything in Parkinson's. Now, I want to ask you, am I sharing my screen? Is that a yes?
Not yet. If you want to hit the share screen.
Okay, yeah, I wasn't
sure
if I was sharing, so I'm going to go ahead and share my screen, and without any further ado, I'm going to start talking about the topic. So anyway, thank you all for joining this talk. I think sleep is a very important, and it's not just my opinion, it's a very important part of life. Part of our lives, and also it's very important in Parkinson's disease. And a lot of the times it goes under recognized or unrecognized. And I've been treating patients with Parkinson's for many, many years, and sleep is something that is not considered as, how should I say, a problem a disorder to treat, because patients with Parkinson's disease, most of them have problems with sleep. So we all know, I think by now, what is Parkinson's disease, first described in 1817 by James Parkinson's. And we do know that it's loss of dopamine producing cells in the brain. In 2010, we had 680,000 individuals over the age of 45 years of age who had Parkinson's, and this number keeps on climbing. 2020, 930,000. 2030, we think it's going to be 1,200,000, closer, or even more. So it's certainly becoming more prevalent. We know that the main problem is loss of dopamine production in a part of the brain that's called substantia nigra. And what was discovered in 1912 was that there are some protein accumulations within those nerves. These are called, it's alpha-synuclein protein, and these are called Lewy bodies. And the pathology usually starts down low in the brainstem, where we call a stage that 1 and 2. And some of the minor symptoms start happening, some autonomic disturbances or olfactory disturbances, where patients lose their sense of smell. And the pathology keeps on going further up in the brain and involving more of the brain. That's when sleep disorders happen, and that's usually when motor disturbance happens, such as the tremor, the stiffness, the rigidity, which is what characterizes Parkinson's disease. And then eventually in later stages, we have involvement of the entire brain, where we do see some cognitive dysfunction, emotional disturbances, etc. But as we all know, tremor, rigidity, bradykinesia is what we see, but a lot of the things under the tip of this iceberg is what we don't see. And these are the non-motor symptoms, out of which it could be sensation abnormalities, behavior changes, sleep disorders, autonomic dysfunction, fatigue. The list is very, very long. It's just, I'm not going to list this here, but focus on the sleep disorders. And we know that they're prevalent. They are present in anywhere between 66 to 90% of Parkinson patients. So almost everyone who has Parkinson's has one complaint about sleep or another. We have REM behavior disorder, which I'll touch more a little bit later. Daytime sleepiness, trouble sleeping called insomnia. Patients have trouble mostly staying asleep, not so much falling asleep. And we have reduced sleep efficiency, as we call it. There's Restless Leg Syndrome, and there's also another condition called periodic limb movements of sleep. We will be talking about each and one of them. If you ever wondered, oh, and I'm sorry, these little icons are in front of the mic text, but if you ever wonder if gender has any role in Parkinson's presentation, the answer is yes. We do see some differences between women and men, and it's really one of my interests to always constantly looking at what does a woman with Parkinson's look like versus someone, a male with Parkinson's. So patients with Parkinson, who are the women, tend to complain more about fatigue, pain. They're more anxious and depressed. They tend to have more restless leg syndrome and constipation. And they have an overall higher disability compared with male Parkinson patients. In terms of male patients, they tend to have more daytime sleepiness, more sexual problems. Smelling, the sense of smell is more problematic, and they tend to have more cognitive impairments. So let's talk a little bit about REM behavior disorder. It's not specific to Parkinson's, but we see it very, 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 very commonly in Parkinson's. And I think most of my patients described them as nightmares, although it's a little bit more than that. The REM behavior disorder the characteristic is patients lose the normal absence of muscle tone when they're dreaming. REM sleep is the dream stage. And normally we all we lose our muscle tone. That's normal. But in patients with Parkinson's disease, they don't have that loss of muscle tone, and their muscle tone is active. And that actually is a problem because they can act out their dreams. And they have these abnormal, disruptive behaviors that start when they're dreaming, and they lead to injuries. A lot of patients can fall out of bed. A lot of patients can accidentally hit their bed partner. So it's a concern when it's becoming severe, moderate, or severe. Patients are talking, laughing, shouting, gesturing, grabbing their partner, flailing their arms. They can be punching, kicking, or leaping out of bed, or even walking down the stairs, or running down the stairs, or even jumping out of the stairs. So it carries a lot of injuries and risk to injury. So it shouldn't be thought as, oh, I'm just dreaming. So we have to really take it into consideration and treat it when it becomes more active. The typical diagnosis through an overnight sleep study where we actually see this, the muscle activity during REM stage, but anecdote, just from the history alone, we can make the diagnosis, especially in someone who already has Parkinson's. We do see it in up to half of patients who have Parkinson's. So this is very, very common for patients in Parkinson's. Interestingly enough, we do know that this condition can start even before the diagnosis of Parkinson's, sometimes even more than like 12 years, to even more than 12 years before the onset of tremors or stiffness. So it can act as a biomarker. It leads to injuries. And we do see that patients who have dementia or hallucinations during daytime, men carry a higher risk, and people who are in antidepressants also tend to have more frequent REM behavior disorder. There has been an article that I like to cite on I'm sorry, this is getting into my screen, so I'm trying to remove it. Okay, that's better. But we went to the different slide. Okay, here we are. So this is the neurodegenerative disease status and postmortem pathology in people who had REM behavior disorder. So what this means is they had 100 people who had REM behavior disorder and had no diagnosis of Parkinson's or any other neurodegenerative disorder. They followed them over 15 years. And they did see that each year, some of them was diagnosed with a neurodegenerative disorder up to 15 years. We did see that by 12 years, about 82% of the patients, the initial 100 patients, were diagnosed with some type of neurodegenerative disease. And the most common one was Parkinson's. 14 patients had Lewy body dementia, one had multiple systems atrophy, and one developed MCI, which is mild cognitive insufficiency. And we know with this study and some other ones that having a REM behavior disorder with no other diagnosis carries a 5-year risk of 35% to develop some type of neurodegenerative disorder. And then in 10 years, these patients have a 75% risk of developing some type of neurodegenerative disorder, Parkinson's being the most common one. This is another similar study. Again, they looked at people who've had REM behavior disorder without anything else, and they kind of followed those patients, and they did develop some type of neurodegenerative disorder. Most of them developed Parkinson's disease. So if someone has REM behavior disorder, we don't necessarily tell them that you're going to develop Parkinson's, but there's the higher risk of developing Parkinson's or some other neurodegenerative disorder. So we just follow these patients. Now, management of REM behavior disorder, it's important, again, when it leads to injuries and when it's bothersome to the patient or the bed partner. We have to educate and counsel the patient. First of all, we have to explain what this is and why it's important to monitor it and seek treatment if and when necessary. One of the things that, if applicable, we advise is to control the aggravators of REM behavior disorder, such as stop the antidepressants. Again, I think this is the most impossible thing to do because you don't want to affect their mood. So most of the times we tend to keep their antidepressants. We do tend to treat this disorder with 2 medications. One is a low dose clonazepam, which is a benzodiazepine, or melatonin. Usually we give melatonin first because we want to avoid side effects of sedation, which is what we see with clonazepam. So we try melatonin. Sometimes if it doesn't work as well, we add on clonazepam. Another interesting study that came out, I think about a couple of years ago, is about the dream content. That is a very interesting concept. Like, what do patients with Parkinson dream of? We know that your dreams are mostly violent dreams or active dreams. You're escaping from something bad or danger or trying to save people or being attacked. So they're not nice dreams, calm dreams. And we really don't know why that is. But they did see that there is an independent association between negative emotions and dreams and a reduction in the cognition within 4 years in a study of 58 patients. So there's a question whether the more negative the dreams are, the more bizarre they are, the higher the chance of developing some type of cognitive dysfunction down the road in the next 4 to 5 years. So we have certainly seen that. We also see that there's a positive association because between negative emotions and this cognitive dysfunction. Now, switching to excessive daytime sleepiness, which is another common complaint of patients with Parkinson's, there's many reasons for it. We do again see it up to 50% in up to half of the patients with Parkinson's. What happens is patients sleep most of the day and then they're awake during the night. And if that happens 1, 2, or 3 nights consecutively, then that becomes a habit and that becomes the norm. So it's extremely, extremely hard to break that cycle. The reason for excessive daytime sleepiness is multifactorial. So a lot of the patients have impaired arousal systems. So in their brain, their system that helps them stay awake is not functioning properly. That affects something called circadian rhythm, that nice clock of our body or our brain to wake us up when it's morning and put us to bed and to sleep when it's nighttime. That is not functioning very well because of Parkinson's. Dopaminergic medication, some of you might have already experienced sleepiness with dopamine agonists or carbidopa, levodopa. That's another cause of excessive daytime sleepiness. There's also the fact that we're going to talk about nocturnal disturbances. You don't sleep very well at night. So that leads to excessive daytime sleepiness because of insufficient sleep. And then some other primary sleep disorders, such as some of you might have sleep apnea, which is not related to Parkinson's disease, but like everybody else, you might have sleep apnea. People who have REM behavior disorders sometimes might have either wake up themselves or somebody like their spouse gives them a nudge and wakes them up because they're yelling or they're kicking. So that leads to fragmented sleep. Restless leg syndrome as well affects sleep. And patients might be exhausted from motor symptoms if they have a lot of dyskinesias, like those Michael J. Fox movements. That might lead to exhaustion. It's almost like exercising the whole day. So of course you will be tired. We do see that excessive daytime sleepiness is more and more common in severe Parkinson's. So anyone who's older in age, men again tend to have more excessive daytime sleepiness, as we mentioned. People who have dementia tend to sleep more during the day and less at night, or if they're depressed. How do we manage sleepiness? Well, we of course dissect what is the real cause of the daytime sleepiness. So if someone's on dopamine agonists, we should either decrease the medication or stop it. If we have to make sure that we keep the patients awake during the day, that's a big challenge. There's good things in living in Texas. One of the good things is our sun, which we have seen plenty of this summer. But let's take advantage of that. Get exposed to sunlight. It's the best way to keep you awake during the day because we function, we sleep and wake up with light or the lack of light. So whenever our brain perceives light, it's going to stop the production of melatonin and will wake us up. So start all the process to wake us up. And the reverse happens when the sun sets. Of course, we have electricity and we have lights on, but when the lights are dimmer or when the light goes away, then our brain starts producing our own melatonin and prepares us for sleep. So make sure that if you're sleepy during the day, go outside or next to a window, whatever it takes for you to be exposed in bright light. Make sure you increase mental and physical activity, whatever that may mean. Get social interaction, go to the gym, do some exercise. There's so many benefits in physical activity and mental activity that I'm sure you all know. We talked about lights, exposure, and then if none of that works, maybe we should consider medications such as stimulants that have been tried, and there's mixed results about whether they can keep you awake or not, but certainly there's a reason for some patients to try them. And then thinking about adequate sleep at night, there's many things we can do, but you might want to consider taking a sleeping pill for a short period of time before you go to bed. Now, keep in mind, if you are sleepy, please don't drive because it's a huge increased risk of traffic accidents, and you should be cautioned not to drive. So insomnia is a huge topic in Parkinson's patients. Well, first of all, the definition of insomnia is either difficulty initiating sleep or difficulty maintaining sleep or early morning awakenings, and either of these accompanied by daytime impairment relating to sleeping for excessive daytime sleepiness. You have, in order to be diagnosed with chronic insomnia, you have to have the complaints for at least 3 times a week for at least 3 months. And I think you'll agree with me, a lot of patients have that. So how common is insomnia? We know that the general population will see insomnia in 6 to 30%, although I think that may be even higher. But in the Parkinson population, it's significantly higher. It can be up to 80%. So a lot of my patients struggle with sleep, which is why I went into and spent an extra year to learn more about sleep in order to be able to help my patients sleep. Who gets insomnia? Let's talk a little bit about the different stages of Parkinson's. So in mild Parkinson's disease, we see that about 1/3 of the patients report that they have trouble falling asleep and also staying asleep. And a few years later, moderate Parkinson's, we see that most of the patients have trouble maintaining their sleep and less so falling asleep. So they fall asleep well, relatively sleepy, but they wake up frequently during the night. And difficulty maintaining sleep appears to be the most common complaint. And it gets worse as Parkinson's gets worse. So what's causing insomnia in patients with Parkinson's is not, again, it's not one cause. Sleep maintenance is a huge problem, and it can affect patients up to 90%. Women have more insomnia than men. This is also a general theme for people who don't have Parkinson's, but also in patients with Parkinson's. Women tend to have more trouble staying asleep. We always like to ask a few questions in patients who can't sleep or can't stay asleep. First of all, frequent urination. How many of you have trouble staying asleep because you have to wake up 3, 4, 5 times during the night to use the restroom? And this is one of the most common and frequent complaints. And sometimes all it takes is treating this frequent urination and your sleep is perfect. And I always love it when that happens because that's an easy fix. Some patients have difficulty turning over in bed. If they're wearing off at night, they become stiffer and they can't move very well. So staying in one place can be very uncomfortable, as if you're on your back on your side for, let's say, 4 hours, 5 hours, that could be very uncomfortable, and pain can start waking you up. Nightmares, but I'm talking about nightmares, not REM behavior disorder, are very common and can wake people up. When patients wear off, we do see that they get sometimes into a dystonia. It could be a limb such as legs, the toes curl, and that's painful, or a facial dystonia, or an arm dystonia. That leads to muscle pain, and that wakes people up. There's also some alert jerks, like a jerking off their legs. REM behavior disorder doesn't really wake people up unless they're woken up by their bed partner again, like just getting an elbow. Hey, you're doing this again, or you're hitting me, or some patients fall out of bed, and that's how they wake up. So these are some of the things that we always need to take into account. We know that patients who have depression and anxiety have a higher risk of getting insomnia. And just remember what we said in the beginning, women tend to get more depression and anxiety. Therefore, they tend to have more trouble with insomnia. Levodopa itself can affect sleep, so it can wake you up. So the duration of levodopa therapy sometimes is affecting sleep. So this is what my brain thinks of when I hear someone coming in my office complaining of insomnia. This is like a very good model of the insomnia model in people with Parkinson's. So if somebody says insomnia, we have to look into their mental health. Do they have any nocturnal motor symptoms? And we'll talk about each of them. Any pain, nocturia? Is it the medications? Is it some sleep disorders that you would otherwise have anyway? And is it behavioral? Is it things that they do that affects their sleep? So in terms of motor symptoms, if you wake up to go to the bathroom, but then you come back and you have a lot of tremors, that will prevent you from falling asleep. Or at the same time, you have tremors and muscle stiffness, or some form of dystonia, which is painful, that will wake you up and keep you up. Or if you're trying to go to bed, you won't be able to go back to sleep. And we talked about the trouble or difficulties turning over in bed. The motor fluctuations is also something similar. It's when patients with at baseline motor fluctuations, they said they had more insomnia over time, and that makes sense because they're having these wearing off motor symptoms at night as well. And they either wake them up, or when they wake up, they have more tremors or more motor symptoms. That creates discomfort in returning back to sleep. So how do we manage the motor symptoms at night? Well, that is easy, the same way that we manage them during the day. But sometimes I see that patients are just may not consider, or sometimes it's not thought that we should medicate or give medications in sleep because you're sleeping. Why do you don't have tremor? But actually we do. If you have trouble with insomnia and you have more symptoms, motor symptoms at night, we should probably start a long-acting dopaminergic medication. There's also a dopamine agonist rotigotine patch, which also improves your morning off times, which is when you get up the first thing, you don't feel so stiff, and they're better overall. There's also the levodopa gel, also called Duopa. That's a constant delivery of levodopa. Some people are using it and they feel that it's very, very helpful. And of course, deep brain stimulation has, although that's not the indication, but we do see that when we turn on the deep brain stimulation, we see an improvement in sleep quality, sleep duration improves, all the PD scores in sleep quality, sleep onset, all of these metrics improve overall, as well as insomnia in patients who have deep brain stimulation therapy. Talking a little bit about Restless Leg Syndrome. First of all, let's all agree to what the definition is, because there's a little bit of I feel in general, a little bit of misunderstanding. Restless Leg Syndrome is not when someone's just moving their legs a lot. I think the name was not chosen correctly. I think all of sleep physicians agree to that. It gives just the wrong message. So restless leg syndrome is an urge. First of all, you get the urge to move the limbs. It's a very uncomfortable sensation. It's not pain. it's something different. It's like everyone comes up with different explanations or descriptions of this, but it is an uncomfortable sensation, which occurs mostly at rest during the end of the day in the evening. And these are partially or completely relieved by movement. So when patients move their legs, that sensation goes away. So if you think about it, restless leg syndrome is more the sensation rather than the movement. The movement is the reaction to the sensation because it makes the sensation go away. And we do see that in patients with Parkinson's, we see up to half of them complain of restless legs, but in controls, in non-Parkinson patients, it's much less. So patients complain of creepy, crawly, tingling, burning, achy sensations. Some of them describe them as feeling like a worm or bugs are crawling deep into the muscle, or like water running under the skin. These are some of the descriptions I've heard. It usually affects both legs, and arms can be involved later on. And as restless legs worsens, we do see the symptoms appear during the day as well, not just evening. So it is also important because if you have this discomfort close to bedtime, it will cause difficulty falling asleep. It will cause less hours of sleep, increased number of awakenings, and sometimes we see restless leg syndrome along with something called periodic limb movements of sleep. What that is basically is moving your legs periodically at certain rhythm. It's not a tremor, but it's almost like a very slow rhythmic movement, which is why it's called periodic, that if it's severe, it can wake you up. It can disrupt your sleep. So we do see that often occur with restless legs. So if RLS is indeed affecting your sleep, we need to manage it, right? Sometimes just managing the restless legs, we see an improvement in sleep. Caffeine, alcohol, antihistamines, some tricyclic antidepressants or SSRIs, these worsen the sensation, the restless legs, and if you can stop them or change the doses, that could be helpful. And of course, stay away from caffeine close to bedtime. One of the things that we like to check is ferritin. Ferritin is the storage of iron. And if you are low, your doctor will give you iron supplements. So that is certainly something that can cause or worsen restless legs. Dopamine agonists are helpful in treating your symptoms. However, now gabapentin, pregabalin have our first line. Now, this changes a little bit with Parkinson's because obviously we will choose to treat with a dopamine agonist versus gabapentin because there's also Parkinson's. It's also medication for PD. So we tend to start with the dopamine agonist first. A lot of patients, like we mentioned, wake up frequently at night because they have to use the bathroom, and that's fine if it's once at night, but it's 5, 6, 8 times at night. That's not okay, and it does disrupt sleep. So why do patients wake up? Most of the times it's because Parkinson's has affected the bladder, and the bladder is not well controlled by the brain. So what I like to say, it kind of has a mind of its own. So it starts contracting when it really doesn't have to contract. I'm talking about the bladder. So that muscle, the muscle of the bladder, contracts, and then you get the sensation that you have to urinate, even though you may not have as much as you thought you would. So the patients go to the bathroom and they see that they do not void as much of a volume that they thought they would void. So this is the reason behind urinary urgency. Of course, there's other reasons why someone can have this urgency. So you should have a urological evaluation to evaluate whether there's other things going on. You might have UTI, you might have prostate, you might have cancer, other things happening. So you definitely have to have an evaluation by a urologist, not a neurologist. And if that's clear, You can do either physical therapy of your bladder, but there's medications that we use, and we tend to use some that don't affect, don't cross into the blood-brain barrier, don't cross into the brain, which some of them tend to affect cognition. So we try to use these oxybutynin and tolterodine, trospium, and so on. Verbitric is a good one. Another medication called amitriptyline can also be used because not only does it help with urinary urgency, it also causes sleepiness and helps with sleep. And of course, limit fluid intake before bedtime. Now, another thing that we always ask is mood disorders. So patients who have depression or anxiety, or psychosis, or are agitated, have what we call sundowning, that's definitely affecting sleep. A few of the things that we also always ask is, what are your behaviors around sleep, and what's your understanding of what we call good sleep hygiene? If you tend to nap during the day frequently, obviously this will weaken this sleep drive, the power of your brain to put you to sleep. So if you have trouble falling asleep and staying asleep, don't nap. Don't weaken that sleep drive by napping. If you have anxiety, depression, then you might want to focus on treating your depression and your anxiety. Anxiety leads to rumination, thinking about this problem over and over and over again. That causes anxiety, and then that's what keeps you from falling asleep. And sometimes people have dysfunctional sleep beliefs. One very common that I'm encountering in clinic is, oh, I turn my TV on because that puts me to sleep. Well, actually it doesn't, because TV has strong lights, and what do we say about lights? It wakes you up. So it prevents the it prevents you from falling asleep, prevents the brain from producing melatonin. Okay. Sometimes we might think about, what are the medications doing to your sleep? We know very infrequently that dopaminergic medications can affect your sleep. Dopamine agonists lead to daytime sleepiness and sudden sleep attacks or episodes of sleep. So you have to be careful when you first start the dopamine agonists, which is ropinirole, pramipexole, rotigotine, you might want to make sure you don't feel sleepy or have those sleep attacks, especially when driving. Medications that can be associated with insomnia are all the what we call acetylcholinesterase inhibitors, the ones that we use for dementia, such as Aricept, memantine, rivastigmine, Exelon. These are the ones. So these cause some form of insomnia as well. And of course, some of the antidepressants may cause insomnia. So this is my favorite part. How do we treat insomnia? Contrary to most common belief, the best treatment for insomnia is not medication. And I know everyone wants a quick fix. Give me that drug. I want to take it and just be out. Well, unfortunately, that drug does not exist. And even if it does, it's not a medication that you can take on a nightly basis. So the best treatment, proven over and over and over again, is what we call cognitive behavioral therapy or treatment. What I like to tell my patients is basically teaching you techniques and retraining your brain and teaching your brain how to sleep, which is putting it very plainly, but they're teaching you what to do, what to avoid, and what to follow in terms of sleep hygiene. They talk a lot about light therapy. They make sure you're exposed to sunlight in the morning or bright light, and in the afternoon, looking for improvements in difficulty of sleep initiation. And we use light therapy in advanced Parkinson's quite a lot because it is not something we can do with medication, because in advanced Parkinson's, especially if you have dementia on top of that, sleep medication would just make the patients more sleepy. So we really focus on light therapy. Exercise is an important piece of helping you with insomnia. We've seen that exercise in the mornings or at midday is the best way to increase that sleep drive. So when you go to sleep in the evening, you feel exhausted and you just sleep much better. Other things such as Tai Chi, low intensity physical activity can help. Meditation can help a lot. And I also mentioned deep brain stimulation as having an impact in sleep. So I'm going to talk about a few steps on how to get to sleep and how to stay asleep. Some of you may know them. Some of you may disagree. But I have to tell you these have been proven to help over and over and over again. First of all, structure. Our brain is a creature of habit, loves structure. So you have to get up at the same time every morning, go to bed at the same time, plus minus maybe half an hour. Make sure you get, I think I said that quite a few times already, get plenty of natural light exposure, especially in the morning, along with exercise. Don't avoid stimulants such as caffeine, nicotine, close to bedtime. That goes without saying. Avoid any thoughts, discussions about topics, well, I want to say politics, that can cause anger or anxiety and frustration before bedtime. Make sure you have a bedtime routine that is very relaxing. Don't watch TV close to bedtime. No screen time, no phones. Do something repetitive, boring. Knitting, for example, is great, or drawing in a very low, dim lighting. That can prepare your brain to put you to sleep. And reserve the bedroom, especially the bed, for sleeping and intimacy. You don't want to be working in your bedroom. You don't want to be eating, watching TV, or whatever else you might be doing, because the bedroom is only, you have to make this association with your brain that the bedroom is tied to sleep. So when you reach that area, immediately your brain is going to prepare you to sleep. No daytime napping. And if despite all this, you're in bed and you're tossing and turning and thinking and sleep is not coming, 15 minutes later, just get out of bed, go back to your living room, TV room, and just try to engage in a quiet activity. Don't turn on the TV, and try to return to bed only when you're sleepy. Now, success, you've achieved sleep. How do we sustain it? How do we keep this precious gift of sleep that our brain has given us? There's a few things that we can do. Again, play with light and noise. Make sure that your bedroom is 100% dark, pitch black. That's what our brain likes. We have to do what our brain tells us to do. And light, again, wakes us up. So make sure that the entire bedroom is dark, no TV lights, no night, well, maybe a night light if you're going to go to the bathroom. So you want to have something there, although I have a tip for that. And make sure that if you wake up at 8 a.m., that you have blackout curtains so that the light doesn't come in, especially in the summer. Don't exercise heavily in the evening, like no exercise within 6 hours of bedtime, because that will wake your body and your brain up, so you'll have more difficulty falling asleep. What happens is exercise increases the body temperature, and our brain does not want to go to sleep when our body temperature is high or our ambient temperature is high. Overall, we want to keep our bedroom temperature low. And I'm slowing down, been smiling a little bit, because I've been doing this thing this year. I'm asking patients what they keep their bedrooms at, especially in the summer. And I hear some, and no one's at the mark where they should be. So what's been recommended by the American Academy of Sleep Medicine is to keep your room temperature somewhere in around 65 degrees. Right? Even, yeah, it's low. It's down there, but trust me, just try it out one day. Okay, of course, get prepared, get your blankets, and depending where you live, but the more north you live, that's more acceptable. Coming down to Texas, no way. So just keep that in mind. And that is definitely helpful quite a bit. Avoid heavy late night meals. Don't have a very, very large meal, especially not followed by alcohol. And make sure that your bedroom environment is right for sleep. It has to be a comfortable bed, obviously dark, quiet, and cool. These are like the 4 pillars of a good night, sustained good night's sleep. The other thing I always tell my patients, should you wake up in the middle of the night, do not check your clock, your phone, your watch. Where are you going to go? It's 3 a.m. in the morning. What's the point, right? So that is what's going to increase your anxiety. Let's say you wake up, it's pitch dark, you have an important meeting at 7 o'clock in the morning and it's 5:30. That's it. You're done. You're never going to go back to sleep because you're ruminating. Oh my God, I'm not going to go back to sleep. And this rumination is just not going to get you down back to sleep. However, if you didn't know what time it was, it's like, it's probably somewhere there, somewhere in the middle of the night. So I'm fine. I'll go back to sleep. So it does help tremendously. Some of my patients have taken my advice of satin sheets and they've told me they loved it. I want to try it one of those days. Still have not tried it. And because they tell me it's really nice because they glide when they're turning over. So it's easier for them to turn over in bed. So that minimizes their stiffness and pain. So try it out if you have trouble turning over in bed. And now, if you wake up frequently at night to use the restroom and you have trouble walking, that is a big risk for falls. This is what we're really afraid of. And yes, leave a nightlight on, but if you feel uncomfortable or if it takes you too long to make it to the bathroom, you might want to consider a commode, just commode placed next to the bedside that you might want to use so you don't have to take the trip to the bathroom. All right, so these are the behavioral modifications, some of them, but let's talk a little bit about medications. So we do have a huge spectrum of different medications, but there are a few that have been suggested for patients who are over 65, and they're recommended because they're not as sedating. Some of them are what we call Lunesta or Zopiclone, Doxepin, melatonin. This is one of my favorites because it doesn't really cause much sedation. And you may recognize this medication, Nuplazid, which its indication is not insomnia or sleep, but it's for hallucinations and psychosis in Parkinson's disease. But we've seen that it can be helpful in sleep. There's a very strong recommendation against all those Z drugs, the Lunesta, for patients who are over 65 and against the use of Doxepin doses over 6 milligrams. We prefer melatonin, Doxepin less than 6 milligrams, the long-acting melatonin, which is called Ramelteon, and Suvorexant, which is Belsomra. There are different ones for sleep onset and sleep maintenance. Since we're talking mostly about sleep maintenance, we're going to talk about very short-term use of Zolpidem, Doxepin, Temazepam, Suvorexant. Again, this is in Belsomra. Trazodone and diphenhydramine are not indicated. I will say it again. Trazodone and diphenhydramine are not indicated. I'm sure within this audience, a lot of you might be on Trazodone. If it's working for you, don't change it. But I would ask your doctor if it's not working for you, because it really isn't such, Sleep Academy is not in favor of Trazodone for a sleep aid. It doesn't help so much with sleep, and it causes excessive daytime sleepiness during the day, and especially in the morning. So you're a little bit cloudy sensation. So we're not suggesting it as a sleep promoting medication. So, and let me just check if so this is more or less how we evaluate someone with insomnia. We go through those different areas and see what the problem is. That do you wear off at night? Then if not, if yes, we consider dopaminergic medication. Do you have anxiety or depression? Consider medications for this. Do you have pain? Do you have frequent urination? Consider medication or behavioral therapies. Any alerting or activating medications? Do you have any REM behavior disorder or sleep apnea? Consider doing a sleep study and treating. First line is CBTI. This stands for cognitive behavioral therapy. Like I said, this is one of the most important therapies and effective therapies in insomnia. Second line, consider exercise. Third line is short-term or long-term therapy with hypnotics. As you can see, their medications come third. So you always have to try everything else before we go into medication. And for patients who are over 65, we want to think about a medication called Demoxipine or melatonin, or as we talked before, suvorexant has also been gaining more ground in patients who are older. And for the younger ones, we can use higher doses of Demoxipine, azopiclone, zolpidem, and more of those Z drugs because they have the xalapone, zolpidem, etc. Okay, I think this is the same one. And with that, I hope that wasn't too much, but I'm happy to answer questions. And I think we have a lot of questions in the chat.
It was wonderful. I have one is just a simple, quick one asking, what was the medication? She asked it a couple of slides ago to help with urinary urges. AMI something?
Amitriptyline.
How do you spell that?
Let me, AMI. Oh, can I type it in the chat?
Sure, because that's what I was going to do. Yeah.
Okay. There you go.
And then we did have some questions about, like more of the standard things, like, can you just do the melatonin over the counter? Or what about chamomile tea? Things like that you hear about.
Yeah, so you can do, yes, melatonin is over the counter. So what's not over the counter is Rameltian, which is the long acting of melatonin. I've had difficulty prescribing it because of insurance coverage. And the other one, chamomile tea. Not enough evidence to support that it helps.
And then somebody asked, is there a connection from for restless leg to Parkinson's disease? Is it like more common in those with Parkinson's disease or just?
Yeah, we see up to 60% more common in patients with Parkinson's compared to patients who don't have Parkinson's. We do know that restless legs syndrome has a connection with dopamine because obviously we give dopaminergic medications and it improves. That does not mean that if you have restless legs, you will develop Parkinson's. So it doesn't go the opposite direction. If you have Parkinson's, you have a higher chance of restless legs because it's some kind of dopaminergic or iron metabolism pathophysiology, so it's not entirely understood what it is, but yes, there's a definite relationship there.
I've always heard of sleep apnea. Someone asked, is REM apnea associated with Parkinson's disease? And so my first question is also, is there a difference between sleep apnea and REM apnea? And then is there a relationship?
That is a wonderful question. So the answer is no. So first of all, sleep apnea is not more common in Parkinson's. Initially, it was thought that it was more common, but that myth has been discredited. So the REM apnea is not more common in Parkinson's disease.
There was question, because you talked a little bit about, I'm very big on CBT, but is basic breathing meditation part of it? Because usually when I think of cognitive behavioral therapy, I think more of like you said, kind of training to rethink things, not so much teaching relaxation techniques. Could you tell us a little bit more about what does it cover? Does it talk about basic breathing meditation? Would that be something different?
It does cover it, yes, and it's a big part of it. Anything that keeps your mind off sleep and falling asleep is what they're working on. And yes, breathing is very important.
What else do they, with the cognitive behavioral therapy, because my husband has insomnia, and I always tease him that I'm like, you should try harder to go to sleep. And, and obviously I say it very tongue in cheek, but I also do joke that I'm like, see, you look at the bed as like your nemesis. Whereas like I get into bed and I'm like, hello, bed, I've missed you all day. And, like, hello, pillow and beautiful blanket. And I don't necessarily think that's what it would be, but I mean, what would be kind of just helping people not having an oppositional relationship with sleep?
I love how you describe it, because the way I describe it to patients is like, you don't want your bedroom to become your sleep torture chamber, because that's what it really is. Like, oh, now I'm going to bed and it's going to take forever for me to, and then you just wind yourself up, and you're having these negative thoughts that without you knowing it, you're preventing your sleep. So it's a given that you won't sleep. So yeah, having that positive connection and affiliation to your bedroom is huge. And this is one of the things that you do with cognitive behavioral therapy. And that's what we say, don't struggle in your bedroom to fall asleep, because it's if you do that, the more you do this, the more you'll become like your husband. So and sometimes it's interesting, if you have trouble falling, if someone who has trouble falling asleep, if they move to a different bedroom, they fall asleep much easier.
One question, is there a max dosage for melatonin? Because that is an over the counter.
Yes, there is a max doses that, well, it depends on what you're using it for. For REM behavior disorder, they've seen that we really stop at 20 milligrams, and that would be the maximum, because beyond, after that, you don't see any benefit and you might see more side effects. I rarely go above 15. And for sleep, it has to be given at the right time, at the right dose, and more doesn't mean better for sleep promotion. So I'm only talking about REM behavior disorder, but if you want to use it for insomnia, it has to be particular, like 2 to 3 hours before your desired bedtime or sleep onset. And it has to be at lower doses, like 1 milligram, like very, very low, just to boost your own melatonin production. Because you're producing melatonin still, if your lights are off.
Start winding down is what I always say. You can't just get right to bed. Yeah, you got to wind down. Well, this was wonderful. Thank you so much for kind of, making my dream, when as soon as you were talking in San Antonio, I'm like, I need her to do this program online. So thank you for doing this today. As always at PMD Alliance, we have a tradition, our wave of gratitude. Thank you so much for being here today. We really appreciate it.
I love that. Well, thank you so much for having me. This is great. And I see there's many questions still unanswered. So if there are some pressing questions, feel free to send me. If they email them to you, I'll be happy to take it offline and just answer. So thank you. Thank you all for listening and your great questions. My God, some of them were really, really good. Yeah. So, all right. Thank you all. I'll have my